Hi, my name is Catherine Anderson Coroner. I run a small consumer advocacy organisation called Active Watchful Waiting. We've been doing something that caught the attention of the Australian newspaper and Sky News, but I feel they've missed the crucial point of our work, hence this video. We audit private gender clinics against Australia's ordinary regulatory standards. That's consumer law, that's professional advertising rules and laws, that's the medical board's code of conduct. Just the rules that already apply to every other medical clinic in this country. What we find again and again is that those ordinary rules are not being applied in this corner of medicine, gender medicine, and almost no one is asking why. So let me start with something most people already accept. If your child went to the doctor with a serious symptom, a suspicious lump, ongoing pain, something that might need treatment, you would expect the doctor to do a few things. You'd expect them to listen, to examine, to investigate, to consider different possibilities before settling on one. You would expect a diagnosis before a treatment plan. You would expect to be told the risks. You would expect to be told the alternatives. You would expect them to know what the current evidence actually says. That's not controversial. That is how Australian medicine is meant to work. The High Court set the modern standard for informed consent in 1992 in a case called Rogers versus Whittaker. In the late 1980s, a woman named Marlene Whittaker had eye surgery to improve vision in her right eye. Her surgeon, Dr. Rogers, did not warn her of a rare complication that operating on one eye could trigger a condition called sympathetic ophthalmia. Apologies if I got that wrong. Causing blindness in both eyes, including the healthy left eye that was not being operated on. The risk was approximately 1 in 14,000. It happened. She lost almost all her sight. The High Court ruled, and doing so, and in doing so, set the modern Australian standard for informed consent. A patient has to be told any risk that a reasonable person in their position would want to know. The Medical Board's Code of Conduct requires it. The National Health and Medical Research Council requires clinical guidelines to be evidence-based. And when the Family Court considered paediatric gender medicine in Recalvin 2017 court case, it declined to require court authorization for hormone treatment in undisputed cases, specifically because it assumed the existing clinical guidelines were providing adequate safeguards. That assumption is doing a lot of work. So our audits ask a narrow, answerable question. In this one corner of medicine, do these safeguards actually exist? We have audited now 16 private gender clinics across Australia. Every single one has been rated seriously deficient, and we've moved up the chain to audit the clinical guidelines those clinics rely on. Let me give you 4 concrete findings. They're all verifiable. Anyone listening can check them in minutes against the source documents. The Royal Children's Hospital Melbourne publishes the Australian Standards of Care for Trans and Gender Diverse Children and Adolescents. Version 1.4 was issued in November 2023 and endorsed by AusPath, the peak professional body. It has 70 references, 70 citations. Every single one of them is dated 2017 or earlier. There are no references from 2018, 2019, 2020, 2021, 2022, or 2023. So what happened in those missing 6 years was not minor. The Cass Review interim report came out. The UK NICE evidence reviews on puberty blockers and hormones, they came out. The Swedish revision, the Finnish revision, the closure of the Tavistock service in London, the US Department of Health and Human Services review. None of it is footnoted. None of it is addressed. The 2023 update added a substantial new section on GP-led prescribing and did not add a single reference dated after 2017. That is documentary failure against NHMRC's own standards for clinical guidelines. Second, informed consent. The same guidelines only consent requirements is one sentence. Informed consent has been obtained. There's no consent form template. There's no list of disclosures that must be made. There's no process for verifying that the young person and their family actually understand what they're agreeing to. And the guideline acknowledges in its own body of text that the effect of puberty blockers on bone development is unknown, that the effect of cross-sex hormones on fertility in adolescence is unknown, that there is no empirical evidence for the right age to start hormones. None of these acknowledgements is converted into required disclosure. They appear in the document. The document does not require them to appear in the conversation with the patient. Under Rogers and Whittaker's, those are exactly the things a reasonable person or young person would want to know. The guideline knows it does not require the doctor to say. The same guideline says as a mandatory criterion that puberty blockers and gender-affirming hormones require diagnosis of gender dysphoria made by a mental health clinician with expertise in child and adolescent development. That is a safeguard. Then in the new GP section added in 2023, the guideline describes a primary care-led prescribing pathway in which mental health referral is discretionary or mandatory, which the GP should discuss this with patients and offer referrals if and as required, unquote. The document does not say which passage governs. A GP relying on the new section may believe themselves to be in compliance with the guideline while not satisfying the guideline's own mandatory criterion. Kelvin assumed that clinical assessment was being conducted to a specified standard. The guideline is internally inconsistent about what that standard actually is. Fourth, the clinics themselves. Across the 16 clinics we have audited, we see the same pattern. Risk disclosure is partial or absent. Alternatives, watchful waiting, psychological support, are invisible or dismissed. A number of clinics are operated by nurse practitioners with no disclosed specialist oversight and no published governance framework. The treatment model is presented as safe, evidence-based, and clinically standard when the independent systematic reviews have rated the underlying evidence as low or very low certainty. The point of these four findings taken together is simple. The safeguards that protect patients everywhere else in medicine, current evidence, informed consent, proper diagnosis, specialist oversight have been removed, one at a time, in this field of medicine, gender medicine. Not by accident, by design of the model gender-affirming care or gender affirmation. This is what I think the public discussion has been missing. The media has picked up on one of our complaints, the ACC complaint against ACON's Kaleido Gender Clinic. It is a strong case, 10 consumer law violations. We've also documented that APRA, the regulator responsible for professional standards, has an active partnership with ACON through their Workplace Equality Index. The ACC has a similar partnership, so the two regulators most likely to receive complaints about ACON's clinic both have institutional relationships with ACON. That is a real conflict of interest story, and it deserves the attention it's getting in the news. But Kaleido is not the story on its own. Kaleido is one of the 16 clinics showing the same pattern. The pattern exists because of the underlying model. There is a name for what had happened, and it's not a political name, it's a structural one. In every other field of medicine, the standard medical model requires diagnosis before treatment, evidence before intervention, full disclosure before consent. That is a load-bearing wall of medical practice. In gender medicine for young people, that wall has been quietly removed and something called the gender-affirming care model has been put in its place. Affirmation is treated as a diagnosis, the treatment, and the outcome all at once. It collapses the steps that protects patients. And this is a part I want to be very clear about. This is not a position on whether anyone should transition. Carefully selected adults with proper assessments will continue to do so. The question is whether the decision is being made the way medical decisions are meant to be made, with diagnosis, evidence, alternatives, and full disclosure. And what we're doing about it, we have submitted formal compliance assessments to APRA and the medical board. We have a program of 49 planned ACC complaints and APRA complaints across so far across 16 seriously deficient clinics with a CLEDO complaint already lodged. We've documented the structural conflict of interest. We are engaging with Parliament and with journalists, and the NHMRC has just begun a 3-year process to develop new national guidelines for paediatric gender medicine. The existing off-path framework is expected to be replaced, and I would say so should be the Royal Children's Hospitals guidelines should be replaced also. So the audits we're doing, they're not about ideology. Looking at this purely from a regulatory process, they ask one question. Does this corner of medicine, gender medicine, meet the standards the rest of medicine has to meet? And so far the answer is no. And vulnerable young people and their families deserve to know that. And if we're dealing with young people, then the safeguards all need to be in place. We cannot be saying on one hand, this is a highly vulnerable cohort children and give them an inferior health care. That's the key point I want to make. I want to say, please, can the regulatory bodies follow the law and follow the regulations that they are supposed to be overseeing? That's it. Thank you.